Everyone, in this lecture we will talk about the orbit. So when you say orbit, we are indicating to the orbital region. We are indicating to the to a pair of pony cavities you see here in this figure. So this is the right and this is the left orbit, and already you have a background about some of the contents there. So what comes to your mind when you say orbit? First of all, it contains the eye pole, and of course its associated muscle. Furthermore, when you say eye and muscles, that means there are nerves, vessels, and of course surrounded by fat, as you see here in this figure. Furthermore, because there is eye, that means we need lacrimal apparatus, as you see in this figure in the superior lateral corner there, to lubricate the eye. So these are an idea about an introduction to the content of the orbit. So when you look to the orbit again, it looks like a pyramid, and you know the pyramid has a base and of course has an apex. So for the orbit, which looks like an pyramid, so this is the base located here outside, while the apex directed medially and posteriorly close to the optic canal. So the pyramid like this, and directed posterior medially by its apex toward the optic canal. So now this orbit, it's like a room, and of course it has a margin and it has walls. So let us start superficially and talk about the margins of the orbit. First of all, you have superior margin, you have inferior margin, you have medial, and you have lateral. So when you say margin, that means just the bridge outside them, the edge outside. So to make it like easier for you to remember it, I would say that all margins are formed of two bones except the superior one, in which the superior margin formed by the frontal bone. Now, from the frontal bone forming the superior margin, let us move laterally, in which you will find the zygomatic process of frontal bone and the frontal process of zygomatic bone. That means the frontal bone and zygomatic bone by their processes. On the other hand, if you move to the other side medially, also the margin formed by two processes, the frontal process of maxilla and the maxillary process of frontal bone. Now let us move inferiorly. Inferiorly, the margin, as you see, formed by the maxilla and zygomatic bone. Now that was the margin, but what about the walls? The walls of the orbit, as I mentioned, which is like a room, it has a roof, it has a floor, and of course lateral and medial walls. So let's start with the roof. I think you remember that we have a brain located here, in which you have a frontal lobe of the brain that's sits on the frontal bone, in which in the orbit there is a plate here related to the frontal bone called the orbital plate of frontal bone. Orbital plate. Orbital because it's form the roof of the eye. Orbit here, something related to the eye. So the roof formed by orbital plate of frontal bone. What else? Also, the lesser wing of sphenoid forms part of the roof. There is one easy way to remember the lesser and the greater wing located there. I think usually in exams they ask the students about the superior orbital fissure. This is superior orbital fissure, which is located between lesser wing and the greater wing. So remember that. That means the roof formed by frontal bone and part of lesser wing of sphenoid bone. That's it for the roof. What about the floor? Floor, of course, occupied by orbital plate, not of frontal bone, no, orbital plate of maxillary bone, I mean, and with a small contribution from zygomatic bone. So this is the floor. Now, moving to the lateral wall. The lateral wall formed, my friend, by the zygomatic bone here and part of greater wings of sphenoid, right? Now, most importantly is the medial wall. This is really important. This is the medial wall of the orbit. It's formed by 4 bones. Don't say that nasal bones form something. It's a way. You can touch it in front of you in the anteriorly, superiorly in the nasal bone. So it's away from the orbit, and it doesn't make any sense to contribute. So what are the bones forming the medial wall? Anterior to posterior, you have, of course, the maxillary bone here. Posterior to it, you have lacrimal bone. Posterior to it, you have ethmoid bone. And posterior to it, you have lateral wing of sphenoid. Some students like confused which one before the other, the ethmoid or lacrimal. I will solve this problem to you. This is the maxilla, right? And this is the lacrimal. Remember L, M. In English, you know, L, M, and so, right? So they are following each other. This is number 1. Number 2, there is a groove here, which is very important to groove. You cannot forget it, called lacrimal groove. And you know maybe that the lacrimal groove formed by the lacrimal bone, and you see part from the maxilla, in which lacrimal sac located here. Anyway, so the lacrimal groove formed by 2 bones, maxilla and lacrimal, so it's easy now to remember it. So medial wall is important. Now, yes, this room, or what we call it, the orbit, has openings. So, and already you have an idea now about the optic canal. Now, this is the optic canal, in which lateral to it you have you remember the lesser wing and the greater wing? Between them there is superior orbital fissure. So this is a superior orbital fissure. When you say superior orbital fissure, that means there is inferior orbital fissure. This is the inferior one. Furthermore, ethmoid, you have anterior and posterior ethmoidal foramina. Plus, what else? You have supraorbital notch and foramen. Supraorbital, that means supra, that means up, above the orbit. On the other hand, you have infraorbital, but this one has nothing to do with the orbit for now. So we are concerned with this, supraorbital notch and foramen. Also, look at the maxillary bone here. You remember maybe V2, which is the maxillary nerve, a branch of trigeminal nerve. It passes from here, maxillary nerve. Once it passes here, this groove called infraorbital groove. Infraorbital groove. Then there is a canal here all the way until it exits outside. This canal called also infraorbital canal. This is infraorbital groove, then the groove continues anteriorly with canal and until it reaches the infraorbital foramen outside. So of course there is a visual nerve carry the same name, infraorbital nerve and visuals, comes from outside all the way until they come outside, and similarly to the superior one. So these are the main openings. Oh yeah, there is one important opening here. You remember the lacrimal groove? Yes, that's there is an opening for nasolacrimal canal. Nasolacrimal canal located here that contains nasolacrimal duct. We'll talk about it. Now, there is this is the components of superior and inferior orbital fissures are very important. You have to know what are the, not just in superior and inferior orbital fissures, but also in the optic canal. But for now, let me remind you with this. This is the right eye. This is from the orbit of the right eye, in which you see the superior orbital fissure and inferior orbital fissure. They form something like more than or less than symbols, right? Anyway, forget this now. And medial to this sign here, there is an optic canal. Let me show you back again. Superior orbital fissure, inferior orbital fissure, and medial to it, optic canal. Now, what this green color? This is a common cold. It's called common tendinous ring. Common tendinous ring. What's the function of it? How secreted? How secreted? We'll talk about it later in this lecture. But for now, I would like to show you where is it. Here is the common tendinous ring. It's the location of origin of muscles of the eyes, right? We'll talk about it. How secreted? We'll talk about that also. But look at its position. It encircles the optic canal. That means passes above the optic canal laterally, and also it divides the superior orbital fissure into two parts, upper part and lower part. So, as you see here, this is the common tendinous ring. So there are structures inside this ring, and there are structures outside the ring, as you see here. Okay, now again, this is superior orbital fissure. This is optic canal. I would start with the easier one, which is the optic canal. Contains, of course, optic canal contains optic nerve, cranial nerve number 2, and the chief artery of the eye, which is the ophthalmic artery, which is a branch of internal carotid artery. So they are inside the circle, inside the common tendinous ring. Now, there is an easy way to remember these structures, abbreviated in this sentence. Live free to see no insult at all. Live free to see no insult at all. So, take the first letter of each word. But before that, when you say I, that means you are, can you guess what the nerves, cranial nerves, pass to the eye? Yes, I will help you. Cranial nerve number 2, 3, 4, 5, 6. Where is number 2? Optic. Yes, here we go. We finish it. Okay. This sentence for the other nerves. Live free to see no insult at all. So, before nerves, you know the superior ophthalmic vein. We talked about it, and in this lecture, we'll talk more about it. And you have inferior ophthalmic vein. Forget that now. Now, live L, which is the lacrimal nerve, abbreviation for lacrimal nerve, which is a branch of V1. Free, that means the first letter of frontal nerve in sequence, right? Lacrimal nerve, frontal nerve, also V1. That means cranial nerve number 5, okay? And here is the trochlear nerve 2. Live free 2. Let us stop here. Live free 2. That means lacrimal, frontal, and trochlear nerve, which is cranial nerve number 4. Okay, finish 4. Why I didn't delete number 3? Because still yet. And why I didn't delete number 5? Still yet we have something here. So now let us get in the ring. What we have other than the optic canal and its content, we have superior division of oculomotor nerve. and inferior division of oculomotor nerve, because oculomotor nerve, which is cranial nerve number 3, divided into superior division and inferior division. When you cut it like this, you will get the superior division and inferior division, and in between there is another branch called nasociliary nerve, which is important for corneal reflex, right? Which is a branch again of V1. So you know that trigeminal nerve, cranial nerve number 5, has V1, which is ophthalmic. Ophthalmic, that means to the eye. V2 to the maxillary, and V3 mandibular. Anyway, we are talking about V1 because we are in the eye. So, and superior division, that means S, which is superior division, I, which is the inferior division of oculomotor, and in between here we have nasociliary. And the last one, all, that means it refers to abducent nerve, cranial nerve number 6. So we finished number 3 with 2 divisions, we finished number 5 with frontal, lacrimal, nasociliary, and we finished number 6. That means number 6 where? It's inside the ring. Okay, that was about optic and superior optic canal and superior orbital fissure. What about the inferior orbital fissure? Do you remember from previous slide when I talked about V2, maxillary nerve, and the infraorbital groove here and the canal until you reach the infraorbital foramen outside? Yes, there is a maxillary nerve, as you see here, passed through the infraorbital groove, then infraorbital canal until it reaches infraorbital foramen outside. Where is that? Let me remind you. Here's let me erase it. Yes. So this is infraorbital groove, then infraorbital canal, not shown here. It's inside the bone until you come to the infraorbital foramen and gives the infraorbital nerve and vessels. Here's just to show you where's the this is the cranial nerve number 5, trigeminal nerve, and this is the ophthalmic division that gives lacrimal branch, live free, live. This is the lacrimal gland, so it gives a nerve to the lacrimal gland. Frontal, this is the frontal nerve that divides at the end to give supraorbital and supratrochlear. Another what we have here is the trochlear nerve for superior oblique muscle. This is superior oblique muscle innervates the superior oblique muscle, right? So it's close to the medially, right? Now again, if you remove a couple of structures, you will get the nasociliary nerve, right? This is the V1 that gives, of course, below the nasociliary nerve that gives short ciliary, long ciliary, right? And gives anterior and posterior ethmoidal, right? So yes, optic canal, we talked about the optic canal, and it has the optic nerve again and ophthalmic artery. Yes, supraorbital notch. This is a supraorbital notch, and foramen contains supraorbital nerve and vessels. Supraorbital nerve, right, is a terminal branch of frontal nerve. Where, let me remind you here. This is the V1 divides again into lacrimal, and here is a frontal nerve. Frontal nerve continues and give supraorbital and supratrochlear. So what you have here, the supraorbital notch and foramen, right? And the infraorbital groove and canal, we talked about it in the previous slide, and nasolacrimal canal. Here is again the lacrimal groove that opens into nasolacrimal canal. If you look at it here, this is the lacrimal sac located here, and this is the duct, nasolacrimal duct. You have to know the difference between duct and canal. The canal inside the bone here, but this, what you see here, is the sac and its duct, right? So inside the canal there is a duct, in which the duct guarded by mucus tissue here to prevent the return of the air from the nose in case when you are blowing up, right? Or sneezing or something like that. The nasolacrimal canal, of course, it communicates ultimately into the inferior meatus in the nose. That's why when you get a foreign body or particle in your eye and there is a lacrimal secretion drained into the nose, so you start have like a runny nose, right? Okay, now it's good to know how's the orbit or this cavity in the face on the skull, how's lined, right? So first of all, you know the periosteum that covers the skull from anteriorly here and around the skull and so forth, and you know the what we call periosteal layer of the dura. So the continuation of those are we call it periorbita. Periorbita. The periorbita lines the orbital cavity, right? Not just the orbital. Once it reaches anteriorly, it gives like a septa called orbital. Here also, it gives orbital septa. Septa plural, septum singular. So orbital to the eyelids, right, to support the eyelid and protect the eye. Now, do you think it's just line this kind of walls? No, but also posteriorly, it's thickened nearby the optic canal, and this thickening create a kind of the common tendinous ring. So the common tendinous ring formed by thickening of the periorbita. This is posteriorly. And also, it's continued as a pulpar sheath. When you say pulpar, that means something related to the eye, and attached all the way around the sclera, which is the white stuff, the white part of your eye, all the way until it reaches the corneoscleral junction. This junction here is the junction between the cornea and sclera, so it stopped here and adheres here, and also it covers the optic nerve all the way around the sclera until it reaches the corneoscleral junction. Do you think it's just like that, lining the walls and make posteriorly a common tendinous ring and covering the optic nerve and sclera? No, but also it covers the muscles controlling and moving the eyes, as you see here. Also look at it here, so it covers also the eyes. What's the function of this sheath once covered the optic nerve and eye, for example, and muscles? Indeed, it separates the eye relatively from the surrounding fat and the structures there and give it the freedom to move with little friction, right? And also it controls the muscles and they preserve their positions, right? So on the other hand, you have a muscle here, inferior oblique, comes from this direction. Also, it includes it. Let us take a cross section here. Look anteriorly, not a cross section. Let us look to the eye from here. Remove the eyelids, right, and these structures to see this fascial sheath of the eyeball. Do you think it's just thickened posteriorly to form common tendinous ring? No, but also anteriorly. Once it reaches there, it also thickened to form a ligament that suspends the eye against the away from the floor called suspensory ligament. Also, it engulfs the inferior muscles of the eye here, and also engulfs, as you know, the medial rectus here and lateral rectus muscle here, because you know, because it engulfs all muscles there. So, but in order to make it like really functional, we need this sheath after all of this covering to fix to the bones. So it gives like an extension laterally and medially and laterally here, and attached to the bones, right, to the bones of the orbit, right? So um, it's attached to laterally and medially by ligaments called cheek ligaments. Cheek ligaments is not a new ligaments. They are a thickening of the same sheath, like suspensor, like common tendinous ring, but they thickened also not posteriorly and inferiorly here, but also laterally to form this ligament. We call it cheek ligaments, right? So the medial one that's attached posterior to the lacrimal crest of lacrimal bone. You know the lacrimal bone and the crest, so posterior to it, it's attached, right? That means lacrimal sac anteriorly. And the lateral one attached, of course, to the zygomatic bone. Now, let us shift to the eyelids. No need to mention that our eyes are protected by eyelids, right? So you have upper eyelid and you have lower eyelid, as you see. Now, this is the this is the superior or upper eyelid, and this is the lower eyelid, and they are meet to each other medially and laterally. So you have medial angle and lateral angle, and the space when you open your eyes, the space or the gap or the distance between the the upper and the lower eyelid, this distance called palpebral fissure. So the palpebral fissure is the distance between the upper and lower eyelid. So when you close your eyes, there is no palpebral fissure. It's about zero, right? Because there is no gap between them. But just to know that the palpebral fissure is a term used for that. Now, if you try to grab your eyelid and try to look what's inside, you will see that it's lined by a mucous membrane. This mucous membrane called conjunctiva. Conjunctiva. So again, this is the cross, I would say, not sagittal, maybe it's a sagittal section of the eye, yes, in which this is the upper eyelid here, and this is the cornea and your eyeball. So the upper eyelid and lower eyelid, of course, here's like it's lined by mucous membrane here. This mucous membrane called conjunctiva. We'll talk about it, and it's not just lining the eyelids, but also it's reflected at this fornix, at this angle. We call it fornix, upper fornix, because this is upper eyelid. That means this is upper fornix, and below it will be inferior fornix. So in the upper fornix, it's reflected on the sclera of the eye all the way until it reaches the border between the sclera and cornea. Here is stopped, right? So here is the conjunctiva. So it has two parts, palpebral part and bulbar part, right? So it's good when you talk about the eyelids. We cannot ignore this muscle, which is very important muscle, innervated by cranial nerve number 3, oculomotor nerve. This muscle because it's to the eyelid, that means something palpebra, and superiorly, and it elevates the upper eyelid. We call it levator palpebrae superioris, right? In which it has fibers inserted in the orbicularis oculi muscles here, and also inserted in the skin, and also inserted in the orbital septum. Inserted in the orbital septum. So, in order to, of course, elevate the upper eyelid. Now, you remember the lining of the orbit? So, the orbit, as I mentioned earlier, it gives like a septa here in the eyelid called orbital septum. Let me remind you that this is the periorbita, or this is like here, erase this. So this is the periorbita. So close to the eyelid here, it gives a septa here, and also this is a septa here called orbital septum. So let me erase this, and here is a better view. So this is the orbital septum that goes down to the eyelids. Now the orbital septum form, of course, it's a thickening at the margin of the eyelid to form the superior and inferior tarsal plate. Look at the orbital septum, it's thickened here superiorly, and of course you have another one here that thickened inferiorly, of course, here. So this is superior tarsal plate, and this is inferior tarsal plate. This is not important because there is something more than this is important, which is the inside it, embedded in it, is a tarsal gland. It's tarsal plate. Inside the plate there is a gland called tarsal gland. We don't usually use tarsal gland. We use meibomian glands, which is a sebaceous gland, right? So now the this tarsal plate, let me show you here. Here is the orbital septum, because you see in the picture it's like that, but that was a cross section. But if you take the whole eye, it's like this, superiorly and inferiorly. So this is the orbital septum, right here, and this is the orbital septum forming, thickened to form tarsal plates, right, up superiorly and inferiorly. Now let me erase it. Now the tarsal plates, as you see here, superior, upper and lower one, they connected to the medially and laterally by medial and lateral palpebral ligaments. Medial palpebral ligaments and lateral one. Very simple. Okay, so we mentioned that in the tarsal plate we have tarsal gland. We call it meibomian glands. Usually use this word, right? Which is long, as you see here, long. I will use another pen here. Okay. So it's long, sebaceous gland that, of course, secrete oily substance. We need it. We need to lubricate this part of the eye. The cornea should be continuously lubricated in order to avoid a damage to this very important transparent structure, right? So you have also eyelashes, also another protection, and look at the meibomian glands. This is from the eyelid, and they are squeezed. So look at the oily sebaceous secretion here. So secreted from here to here once it's really squeezed, right? So sometimes it's obstructed. lead to like swelling and redness on in the eyelid, right? Back again to remind you with the upper and lower eyelid that lined by a mucous membrane, which is the conjunctiva. Right, so this is the palpebral conjunctiva. It not just the conjunctiva, not just lines the eyelids, but also it moved now from this fornix. It also covers the sclera of the eye, the white color of your eyes, right? Now this part called bulbar conjunctiva. Look at it here. This is a cross section. This is the eyelid. So inside the eyelid you have the palpebral conjunctiva, and this is the upper fornix. That means the upper corner of the eyelid, and this is the lower fornix or inferior fornix. Then the conjunctiva now reflects on the sclera of the eye until it reaches the cornea. So it doesn't cover the cornea. No, cornea is transparent. Nothing covered the cornea, right? So this is the bulbar part. So you have my Pomuni glands, and you have also another sebaceous gland, which is a gland of C's here that opens into the hair follicles, right? Sometime inflamed or obstructed, lead like to small swelling or redness here, right? But you have also a sweating gland called the gland of Moll. You have a gland up like Wolfring, modified lacrimal, accessory lacrimal gland, and also glands of cross that also again accessory lacrimal gland as well. Lacrimal glands, yes, lacrimal glands are very important because it's really the function that its roles really in protecting the eye and lubricate the cornea, and it has also different substance to nourish the eye and cornea and structures there. So lacrimal gland, you have to know, which is very important, that's located in the superior lateral region of the orbit. So this is medially, right? This is your nose here. So this is your eye. So in the superior lateral region, superior lateral corner of the orbit. So it's hidden, right? And also the lacrimal gland divided by, you remember the levator palpebrae superioris muscle, we talked about that elevates the upper eyelid. Yes, by its tendon, it separates, not completely, but as you see here in this figure, the lacrimal gland into two parts, one related to the orbit, and this one, which is called the orbital part, which is large, and also one related to the eyelid, which is called palpebral part, which is smaller than the orbital. So the lacrimal gland has around 12 lacrimal ducts open again into the lateral part of superior fornix of the conjunctiva. Where is the superior fornix? That's why I talked to you about the fornix here. So let me remind you, this is the conjunctiva, the palpebral one, lines the upper or lower eyelid, and here is the part that covers the white color of your eye, the sclera, I mean, but there is a corner here, the reflection here, and also you have a corner here. So this is the upper fornix, and this is the lower fornix of conjunctiva. You have to pull your eyelid to see this area, right? Like for example, in this eye, somebody like pull the, so this is the edge of transition. This is the lower fornix, and if you take the upper eyelid up, this area here will be the upper fornix. So the Lacrimal gland located here, and the ducts open in the lateral part of the superior fornix or upper fornix, superior fornix of the conjunctiva, as you see here. So the secretion will be drained into the eye, lubricate the eye, nourish the eye, then and wash out of all, of course, the eye. Then the tears reach the two small canadiculi medially, right? One above and one below. You can see those opening puncta. We call it lacrimal punctum or puncta here. Let me show you here in this figure. Here is the punctum lacrimalis. Punctum lacrimalis. Here is one, right? There's another one here. So there's a canadiculi here, right? So this an opening, you can see it in your eyes, right? So just once the tears like reach or the secretion reach there, they of course absorbed and pass through the lacrimal canadiculi from the puncta and drained into a lacrimal sac located in the lacrimal groove, right? Now from lacrimal sac drained into nasolacrimal duct. So this duct is, you see here, is short, is about 1.3 centimeter, right? And it opens into the inferior meatus of the nose. That's why when you have a foreign particle comes to your eyes, then start the lacrimal gland to secrete tears and so forth, then you will find yourself with a runny nose because of this lacrimal apparatus there. So these informations really regarding lacrimal apparatus are important. Now, blood vessels, sorry, in the orbit. Well, it's obviously known that the ophthalmic artery is the chief artery there, which is a branch of internal carotid artery that passes at the first lateral and inferior to the optic nerve, then it twisted to become superior to it. However, it comes very important branch to the eye, which is the retinal the central retinal artery, and also it gives to the lacrimal gland and the ciliary to the eye, and also it gives the supraorbital and supratrochlear artery in addition to the ethmoid ones. Now veins, already we explained this in a previous lecture before maybe 1 week or so, and we mentioned that we talked about the danger area in the face, and we mentioned that the ophthalmic veins, especially I'm talking about here, let's start with the superior ophthalmic vein that communicates with the fascial vein, drains into cavernous sinus. That means they are source of carrying infection from the face or an area there to the cavernous sinus and the cranial cavity, right? Now also you have the inferior ophthalmic vein that also communicates through infraorbital fissure with the pterygoid plexus of veins there, and it drains either directly into cavernous sinus or sometimes it drains into superior ophthalmic, then superior ophthalmic into cavernous sinus, and this is really important. Yes. Now this, although I prefer to explain the muscles within the orbit in the lecture of the eye, but let us have introduction about the muscles within the orbit. Well, indeed, in the orbit you have a very important structure, which is the eye. And the eye pole, my friends, moved and controlled by muscles, right? So you have outside the eyeball, these muscles are extraocular muscles. Extraocular muscles. But there is also muscles inside the eye. We call it intrinsic muscles inside the eyeball itself, right? So the intrinsic muscles controls what? No, they don't move the eye. No, they control the shape of the lens and the size of the pupil. You have to memorize these two things, right? So let us start with the extraocular muscles outside the eyeball. So you know the levator palpebra superioris, already we finished it. We have 4 recti muscles. That means we have one superior to the eyeball, one inferior, one to the medial, one to the lateral. So you have superior rectus muscle. You have also, if you look inferior here, there's a shadow of inferior rectus. Superior and inferior rectus. Also, you have medial rectus and you have lateral rectus muscle. So these muscles, the recti muscles, first of all, the origin of these muscles come from the common tendinous ring. Do you remember? This is the common tendinous ring. Do you remember it? Let me remind you with that. This is the common tendinous ring formed by a thickening of periorbita posteriorly, right? This is a common. So it's the origin of recti muscles: superior, inferior, lateral, and medial recti muscles. So this is the common origin of these muscles, right? The recti muscles, the 4 sisters, I would say. And what about their insertion? Look at the eyeball here. If you divide the sclera into 2 halves, right? So look at the recti muscles. The superior inserted in the anterior half of sclera, right? In the anterior half of sclera. Also the inferior rectus, also the same. Lateral, let me erase this. Okay. The lateral rectus also inserted here, in the anterior half of sclera. Medial rectus also inserted here. So all the recti muscles inserted on the anterior half of sclera. This is number 1. All they are originated from the common tendinous ring, as you see here. This is number 1. Number 2, you have 2 other muscles. They are oblique muscles, one superior and one inferior. Let me erase these things again. So look at this muscle, originate from body of sphenoid. It looks like from the ring, but it's not from the ring. It's from body of sphenoid here, right? So this is the superior oblique. Why it's oblique? Because once it reached the medial side here of the orbit, it twisted around the trochlea here to change its direction and function. So it's the superior oblique. And look at its insertion here. So again, if you draw the line to show the anterior half and posterior half of the sclera, so it's inserted in the posterior half. Oblique muscles inserted in the posterior half of sclera. This is superior oblique. What about the inferior oblique? Okay, let us look at here. This is the inferior oblique originates here from the floor of the orbit and inserted here laterally. Again, it's inserted in the posterior half of the sclera. One thing is very important, not just to memorize it, not for just exam, but also for your life. As a physician, you have to know how to test those muscles, and you have to figure out which nerve is affected. So what I'm gonna say that this is very important to know that all muscles of the eye supplied by oculomotor nerve, which is a cranial nerve number 3, except all of these muscles, right? All 7 muscles innervated by oculomotor nerve except the lateral rectus muscle and superior oblique muscle. That means this muscle, the superior oblique and the lateral rectus, they are innervated by, when you say superior oblique, that means by trochlear nerve, cranial nerve number 4. Remember the trochlea here that twisted the muscle. Look, remember this trochlea. Remember trochlear nerve for superior oblique. The trochlea of superior oblique, so trochlear nerve. And remember that this is lateral rectus muscle, right? Lateral rectus, once contracted, it moves the eye laterally. So your eyeball becomes like this, to look laterally, to look to the sheath of your colleague. It's the muscle of cheating, I would call it, right? So it's abducting the eye from its center, right? That's why the nerve that supplies it is the cranial nerve number 6, right? Which is the abducent nerve. Abducent nerve. So the superior oblique by trochlear number 4 and lateral rectus by cranial nerve number 6. Trochlear abducent nerve. Okay. Now, what you can figure out from, yes, you need to know these muscles, and already I explained the origin and insertion, so it's like they are easy for you if you want to read it, and the innervation, which is very important, right? And because all they are innervated by oculomotor nerve except the lateral rectus, which is by abducent nerve, and superior oblique by trochlear nerve. Now we are curious very much about their function. Yes, it's very important to know the function of each muscle, how they are coordinated with each other. Let me explain to you. First of all, you have to know. I will give you rules, right? So the recti muscle, they are very simple. For example, you have lateral medial rectus and you have lateral rectus. You have superior rectus and inferior rectus. First of all, forget what's written here, right? The superior rectus move the eye up. Let me go back here, right? So the superior, forget the levator palpebra. Here is the superior rectus muscle. Once contracted, it pulls the eyeball up, right? And the inferior, but this is not just up, but also it adducts the eyeball. Now the inferior rectus, it once contracted, you imagine it pulls the eyeball down, it depresses the eyeball, move it down, and also medially and adducted, right? Now the easier two muscles are the lateral rectus and medial rectus. The medial rectus, just once contracted, it moves the eyeball medially. Lateral rectus move the eyeball laterally. We finished the lateral rectus and medial rectus. Back again to superior rectus. Look at the superior rectus here. Let me erase these things again. So again, this is the superior rectus, in which, imagine once contracted, it will pull, it will elevate the, or move the eyeball superiorly, and also it adduct. That means recti, especially I'm talking about superior and inferior, they adduct, ADD. That means, for example, superior rectus, it elevates the eye pole, and look at its insertion, look at the angle of the eye pole related to the axis of the orbit. This is the axis of this is the orbit, right? So this is the axis of the orbit, and look at the axis of the muscle, right? So once the superior oblique muscle contracted, it elevates the eye pole and move it, because look at the insertion, it's like obliquely inserted a little bit relatively to the axis of the orbit, right? So mainly it will adduct the eye pole medially, right? So this is superior rectus. Also, inferior rectus. Inferior rectus, once contracted, depresses the eye pole and move it medially. Adduct it, I mean, right? Now, because also of the perpendicular axis, kind of the axis of the muscle to the orbit, the superior rectus muscle medially rotate the eyes, right? So what does it mean? That means the eye pole medially rotated, not just adducted, but medially rotated, right? So this is about the superior rectus, and back again here. So this is the superior rectus. Elevate the eye, it adduct the eye, and medially rotation of the eye. Now, what about the inferior rectus? I'm trying to let you understand what's written in this. So we said that the inferior rectus depresses the eye, adduct it also, because we said that rectus and rectus superior and inferior, those recti muscles will adduct the eye pole, but the inferior rectus will laterally rotate the eye, not medially, because there is I would say, a kind of a rule which is easy to remember, that superior muscles, regardless if they are recti or oblique, they make a kind of medial rotation of the eye, right? Medial rotation. While the inferior muscles in the eye move the eye laterally, rotate it laterally, right? This is an easy way to remember, right? This is the eye. So muscles, the superior muscles move the eye medially, right? If this is your nose here, right? And the inferior muscles move the eyeball, rotate it, I mean, rotate the eyeball on itself laterally. So I don't want to make it really complicated, but you know, medial rectus, lateral rectus, very easy muscles. Medial rectus, adduct the eye. This is medial rectus. We talked about it. Lateral rectus, pull the eye laterally. That's it. We finished these muscles, right? Now, we finished also this muscle, levator palpebrae superioris. Now, what about the superior oblique and inferior oblique? Okay, let me erase this also. Yes, we said that the superior oblique originates from the body of sphenoid and moves medially. This is medially, right? And this is laterally. Moves medially until it reaches the trochlea in the medial wall of the orbit. Then it changes its direction, and of course its function inserted in the posterior part of the posterior half of the sclera. Imagine when it's contracted. Imagine what will happen is that it moves, it works against its name, its superior oblique, but once contracted, it pulls the eyeball down. It depresses the eyeball, like when you are looking to the ground, right? So this is number one. And look again to its insertion, right? Its insertion in the back, in the posterior half of the sclera. So once contracted, it will move not just the eyeball inferiorly. It will not depress the eyeball, but it will also rotate it laterally. It will abduct. It will abduct the eye. But regarding the rotation, no, we said that superior muscles internally rotate the eyes like this, right? So there are three terms, my friends. The movement of the eyeball itself and the cornea, for example, in the oblique muscle. So depresses the eye down, like when you are looking to the ground. This is number one. And it's adduct or abduct. No, the oblique muscles, superior or inferior, the oblique muscles are abducting the eyeball. Move it in this direction, also a little bit in this direction. I will show you after a couple of slides. This is number two. And lastly, the rotation of eyeball itself, it's internal rotation. Because look at the insertion, you need to imagine the eyeball will move down and laterally, and it will rotate itself, around its axis. It will rotate internally, right? Because we said that superior muscles, regardless what they are, they internally rotate the eye, while inferior muscles, they externally rotate the eye, right? So what about the inferior oblique? This is the inferior oblique muscle. Now we said, yes, we have superior oblique, and also we have inferior oblique that originate from medial floor of the orbit, posterior, of course. Also from maxilla, lateral to the nasolacrimal groove, and inserted in the posterior half of sclera, right? Imagine once contracted. We said that oblique muscles work against their function, against their names. Inferior oblique moves the eyeball up, like when you look into the roof, right? This is number one. And also we said that oblique muscles abduct the eye, move it outside, right? So in this case, if you take this eyeball, it moves up and a little bit laterally, abduct. And what about the rotation? We said that the inferior muscles at all, they are laterally rotate the eyeball, because when it's contracted, the eyeball moved like this, laterally. So now I can explain this, what's written here to you. This is a plan not to the location of the muscles. No, it's related to the function, anatomical action, the function. For example, let us finish this is medially, right? So medial rectus moves the eye medially, adduct the eye toward the center, to the nose, right? Adduct. While the lateral rectus abduct the eye, move it laterally. We finish it. Okay. Now, the superior rectus elevate the eye. Inferior rectus depresses the eye. But wait. Who's also superior rectus? Yes, elevates the eye. Who's also elevates the eye? Inferior oblique, because we said that oblique muscles works against their function. Inferior oblique elevates the eye, while superior oblique depresses the eye. That means superior rectus and inferior oblique, both they elevate the eye. If they are working together, this is the result in the middle, elevation of the eye. Again, Inferior rectus depresses the eye. Superior oblique depresses the eye. Together, they depresses the eye in the normal position, right? But now, superior rectus alone, superior, because this is medially, remember, this is your nose is here, right? So, the superior rectus, it elevates the eye and adduct it, move it medially. While the inferior rectus also depresses the eye. Superior rectus, yes, here is inferior rectus. Inferior rectus depresses the eye and move it in this direction, adduct it toward the center, right? Because we said recti muscle adduct the eye. In addition to their function, they adduct the eye. While the oblique muscles, which is I really don't like, they work first of all against their function and they abduct the eyes. For example, inferior oblique, yes, elevates the eye and abduct it. Superior oblique depresses the eye and abduct it away from the midline. This is how to test the muscles. Take care. It's not similar to their action completely. So, for example, if you need to test the lateral rectus muscle, you ask the patient to look laterally. That's very simple, straightforward. Similarly, if you want to test the medial rectus muscle, you ask the patient to look medially. We finished it. That's very simple, straightforward. Now, and we finished here and we finished here. Now, the idea that you need to give it extra attention for the overlapping or muscles that they work some kind of the same function. How can you differentiate? For example, you know that the superior rectus and inferior oblique, listen, inferior oblique, I'm talking about this diagram again shows the names of the muscles and and their functions, right? Because you know inferior oblique is located here inferiorly, but it's indicated here to show that the inferior oblique and superior rectus, they both elevate the eye both superiorly, but the superior rectus alone, its function is to elevate and adduct. But inferior oblique alone, it works as it elevates the eyeball and abduct the eye. That means move it laterally, right? But both together they elevate the eye in the middle, right? But somebody can say, I want to test the superior rectus alone. So this is the superior rectus. How can we test it? You know that superior rectus functionally it elevates the eye and adduct it, move it medially. Why now we asking the patient to look laterally first, which is against its function? Because we know superior rectus move the eye medially. Yes, it elevates the eye and move it medially, adduct it. Why now we ask the patient to look laterally, then upward? Yes, I can understand that. Yes, superior rectus elevates the eye. That's, of course, I will ask the patient to look up, right? Move his eye upward. But why first we have to ask him to move it laterally? And why laterally, not medially? Listen, if you look here back in this figure, I will erase. Here is the idea. Look at the superior rectus muscle. Let me draw the axis of the superior rectus muscle. This is the gaze axis of superior rectus. And here's the axis of the eyeball. So, in order to isolate the superior rectus is in here. In order to isolate the superior rectus from the inferior oblique, because both elevates the eye. So in order to elevate it, we will ask the patient to look laterally. Now imagine when the patient looks laterally, the eyeball will move to this direction laterally. That means these dotted lines, the axis of the eye and the axis of the axis of the muscle and the axis of the eye, now they will match each other. They will overlap each other and they are on the same direction. Now you isolated the rectus muscle and now you can test it, right? So you ask him to look laterally. Once the patient look laterally, what will happen is that the eyeball now becomes like this. This is the cornea, and this is the axis of eyeball, and this is the axis of, say, example, this is a rectus muscle, and this is the same axis of rectus, superior rectus muscle. Now you isolated this muscle, right? Similarly, if you that's why you ask him to look laterally. Now you make, there is no difference between axis. Now you ask him to look up. Now you test the superior rectus muscle alone, right? Similarly, the inferior oblique, when you want to test it, yes, you will ask the patient to look upward, but before that, you have to ask him to look medially, right? Because similarly, the eyeball will straighten because, say, for example, this is the inferior oblique, and this is superior rectus, and here is the eyeball, right? So, if I'm correct, this is the axis of the eyeball, and and this is the axis of inferior oblique, right? So you need to ask the patient to move his eye medially. So this green line, the axis of the eye, now becomes parallel to the inferior oblique axis. Now 0, yes, now you can test the inferior oblique. Now ask him to elevate the eye. That's why for the inferior oblique now, yes, you ask him not laterally, you ask him to move his eye medially, then upward. You test it, that's fine. And the same story with inferior rectus and superior oblique. First of all, you have to straighten the gaze or the axis of the eyeball with the axis of that muscle, regardless where's that muscle, right? So usually if you notice that you are, you are testing the second function, but before testing that second function, which is fixed, right, you are, because superior oblique, yes, move the eye downward, inferior oblique upward. We know the inferior rectus, move eye downward, but the idea, the trick here is you are opposing the other function of that muscle. For example, superior rectus moves the eye upward and medially because it adducts the eye. Now you ask the patient, before the testing the major one, the upward, you ask him to move his eyes laterally against its function. Because why the function, why also you can ask why its function adduct? Because of the axis, because of the change of the axis. Now the function adduct, but you need to test you need to separate, isolate the muscle itself. That's why you ask him to look to the opposite second function, which is the laterally. So the arch test, which is common, you ask the patient to look for you, then you follow the arrows. You are looking as arch shape, right? 1, 2, up, then down, then back to the left side, down and up. So you're testing all muscles. Here also you can read it, and for example, let us say this. Your this eye, left eye moved up. Yes, superior rectus or inferior oblique. Now, medially, superior rectus, because superior rectus moves the eye up and adducted. Inferior oblique moves the eye up and abducted laterally, right? That's why it is inferior oblique. Opposite to it, the other, this one, right? Because you start from the primary position here. Look up. Who's moving you up in the center like this? Superior rectus and inferior oblique. While inferior looking to the floor, the inferior rectus and superior oblique, because you know superior oblique muscles work against their function. Okay, thank you, and see you next lecture in the eye. Thanks.